And thank you very much. Welcome everybody here this evening. Like to introduce ourselves. My name is Peter Dottino. I'm a GYN oncologist. I practiced in Manhattan for 30 years and moved to Yale about a year and a half, 2 years ago, and worked in Greenwich and in New Haven, as does Dr. Papatla. Hope Walden, our APRN, joined us. And we now have a GYN oncologist at Greenwich, 5 days a week, available to see patients, available for phone consults or just questions. If you have any questions about any management issues in gynecologic cancer that you want to run by us, one of us was always available to do that. We've done this, put this together really in two ways, is just to bring you some basic knowledge and also as an opportunity to introduce ourselves to you and bring you some of the update information in our field as it may be useful to you as you look around and see what patients would be appropriate for referrals or things that you may need clarification on. Like I say, we will be available. We're available 5 days a week at Greenwich, so please don't hesitate to reach out. My charge this evening is to give you some of the basics of where we are in endometrial cancer, diagnosis, management now, that's what I'd like to give a start with.
All right, I'm going to share. You ready for your slides?
I am ready.
Okay. Give me a second and I will get this going.
All righty.
Let me get it into presentation. There you go.
There you go. Thank you very much. No, I have no conflicts of interest to report tonight. It's not moving forward for some reason.
Oh, hang on. How about now? No?
Yes. Hold on. Let's see. So tonight we're going to be talking about endometrial cancer, early stage, and also precancerous condition. I'd like to run through the epidemiology, the disparities that exist in endometrial cancer today, the risk factors, prevention and treatment, screening, early diagnosis, prevention and treatment. And if we get through that in time, I will go over a little bit about Lynch syndrome and its relationship to endometrial cancer. It's not letting me move forward.
I'll move it forward for you.
Oh, okay. So
you just say next slide and I'll do it.
Perfect. Endometrial cancer, as you may or may not know, it's estimated there's going to be about 66,000 cases in 2023. It's the third most common cancer that affects women, breast, lung, and colon being the top three. And what's been projected to happen in the next 3 to 5 years is that colon and rectal cancer are going to drop to the bottom, secondary to the extensive screening programs that are out there. And what's going to be the third most common cancer to affect women is endometrial cancer. 7% of all new cancer cases are going to be uterine cancer. It's the fourth most common currently, and it accounts for about 5% of female related deaths. The next slide, please. And as we can see here, both the incidence and the mortality of endometrial cancer are increasing. Mortality rates have been rising faster, and this is most likely due to the increasing number of high-risk subtypes, which we're going to discuss as we go through the talk. Next slide, please. There are two classifications of endometrial cancer that are commonly used today. One is the traditional classification, and the second is the molecular. The traditional classification has two subtypes, a type 1 and a type 2. And the way we distinguish that is really phenotypically. Type 1 patients, as we'll see, tend to be obese. Type 2 patients tend to be very thin. So there's a clear difference. There's been an ongoing move over the last 10 years, and a lot of it's been driven by the investigators here at Yale and Smilow towards a molecular classification of endometrial cancer. And I will go over that with you also. Next slide, please. So again, the profile of type 1, which is going to make up 70 to 80% of all new cases of endometrial cancer, are going to be obesity, slightly younger aged women, some women that have polycystic ovary disease, unopposed estrogen syndromes, which will lead to endometrial cancer, precancerous conditions called hyperplasia, endometrial hyperplasia or atypical hyperplasia. These are commonly referred to as EIN or AEH, endometrial atypical hyperplasia. Endometrioid cancer is the most common pathology, and the type 1s are going to be associated with estrogen and progesterone receptors positive, KRAS P10 mutations, and occasional mismatch repair gene deficits. Next slide, please. Type 2 cancer, which is making up between 10 and now almost 25% of all the new cases of endometrial cancer. And again, these are going to be women who are very thin, and they will have high-grade endometrioid cancers or non-endometrioid cancers, which would be clear cell type, or what we call UPSC, which is uterine papillary serous cancers, or possibly even carcinosarcomas. These are not hormonally driven cancers. These arise from an endometrial intraepithelial carcinoma, referred to as EIC, which is a precursor for specifically for the papillary serous carcinoma, which is the most common cell type in type 2. And again, most often, type 2 will arise in a background of atrophic endometrium on a sonogram, as opposed to a thickened, irregular endometrium on sonogram for type 1 patients. These will pursue an aggressive clinical course with metastasis in about 60%. Recurrence rates are high in stage 1, about 23 to 25%. And again, these are in elderly, non-obese, menopausal women. These are going to be treated much like we treat ovarian cancer. These will get surgical staging, and they will be followed with dose-intense chemotherapy and vaginal brachytherapy, as we'll see. Next slide, please.
Oops, sorry.
It's okay.
There we go.
There we go. So again, the type 1 or the estrogen driven, they tend to be low-grade tumors, diagnosed very early. They have an excellent prognosis. Only 20% on presentation will have local regional spread, and only 8% distant metastasis. The type 2, again, higher risk, aggressive histologies, more common to have extrauterine disease. At the time of diagnosis, they carry worse prognosis. And again, those are going to be grade 3 endometrioid or uterine papillary serous cancers or clear cell cancers. Next slide, please. Now, when we look at the molecular classifications, this was based on TCGA data. And again, Yale was a participant in this. And this was an effort they sequenced over 350 cases of endometrial cancer, and they were able to put them into 4 different categories and predict outcome based on these categories. And these are just names, but in category 1, we have what we call POL ultra mutated. Number 2 is microsatellite unstable, hypermutated. Number 3 is copy number, mutation copy number low, and number 4 is copy number high. And you again, typically with the serous. And we'll take the next slide, please. And again, why this is important is we know that those patients that have a POL mutation have an excellent prognosis with rare recurrences. And we know that those patients with a high copy number, like the serous types, have a very poor prognosis. Those we now know can, as I said, were treated with chemotherapy like ovarian cancer, which includes Taxol and carboplatin. We've now added, if they have a HER2 positivity, we use Herceptin as part of their treatments. And the two middle types, the MSI high and copy number low, are also now treatments are available for these. And this is where immunotherapy has come in to play a very large role in this. So this is a new classification. Some centers, very few in the US have yet adopted this, and most people in most centers stay with a type 1 and type 2. But ultimately, the molecular classifications for all cancers are going to be the way patients are treated, not based on the histology or the site of origin, but they're going to be treated most likely based on their genomic analysis. Next slide, please. So again, the type 1 low grade is preceded by a pre-invasive condition called hyperplasia. Classification by the WHO, you can have hyperplasia without atypia, which is a very benign condition, which very rarely progresses to endometrial cancer. And then you have atypical hyperplasia, which is a direct precursor to that. About 8% of benign hyperplasia will progress over a period of about 8 years or so to endometrial cancer. And when these are identified in type 1 hyperplasias, the vast majority of these can have a chance to be reversed with hormonal therapy, and in many cases, avoiding safely hysterectomies. Next slide, please. And this is a slide to give you an idea. On the left-hand side, this is a normal endometrium, and on the right-hand side, you're seeing hyperplasia. And what happens is the glands that form begin to crowd on each other, and you lose some of the stromal component here. And that's how the diagnosis is made. And the risk for developing cancer in the non atypical hyperplasia is 4 to 8%. And again, those women can be easily treated with either DNC, where the lining is scraped, or with progestins. Next slide, please. As this hyperplasia progresses, you can see what's happened here. The glands have essentially crowded out all of the stroma, and you can see how thick the glands are with cytologic abnormalities in the glands, and that's what makes a diagnosis of the complex hyperplasia with atypia. Next slide, please. And so what we know about these is that the EIN, the atypical hyperplasia, if not treated, can progress to endometrial cancer within estimated about 12 months. We also know that when we do hysterectomies on women in the menopausal time who have atypical hyperplasia, 30 to 40% of the time when the uterus is removed and it's sectioned, we will find a very early grade 1 cancer at the time of definitive hysterectomy, which in most cases will be cured just with the hysterectomy alone. And again, the EIN and the type 1 endometrial cancers both share the risk factors, symptoms, and signs of irregular bleeding, heavy bleeding, or postmenopausal bleeding. And again, the management is going to be treated with hysterectomy, with potential exceptions in very young patients where we can actually preserve their fertility. Next slide, please. And this is endometrial intraepithelial carcinoma. Now, this is a precursor to the type 2 aggressive form of endometrial cancer. Okay, and you can see from the slide here that this actually has some hobnailing appearance. This tends to be stained for P53. And this is a precursor directly to the serous type of aggressive endometrial cancer. But it does have a defined precancerous condition. Next slide, please. So again, we're talking about 9 hereditary types of type 1 endometrial cancer, risk factors: nulliparity, irregular menses, polycystic ovary syndrome as a 3 times increased lifetime risk, endometrial cancer. The mechanisms are believed to be through hypersecretion of LH, increased glucose, hyperinsulinemia, insulin resistance, insulin growth factor, inflammatory responses, exogenous estrogen, where women are given postmenopausal hormone therapy, but they're just given estrogen without progesterone to balance it. It drastically increases the risk for endometrial cancer. Tamoxifen can also, if used for prolonged experiences, is reported to actually cause endometrial cancer also, in addition to a whole host of benign endometrial changes. Endogenous estrogen can come from estrogen producing ovarian tumors called granulosa cell tumors, ovarian stromal hyperthecosis, or prolonged anovulation without periods, which is not uncommon in polycystic ovary cancer. Driving the base of this, as we alluded to, is going to be obesity, because in obesity in the fat cells, particularly on the abdominal side, you get peripheral conversion of other hormones into estrogen. And you can see in the bottom that as the BMI increases, goes from 25 to 25, 25 to 29, you get a 2 to 3% increased risk. When you go BMI to 30 to 39, the risk goes up to 3.7. Over 40, it's 13 times. So there's no question that the driver behind increasing frequency in endometrial cancer, moving to the 3rd most common cancer that affects women in this country and worldwide, is the obesity epidemic that we now live with. And as you plot the number of cases versus the increasing BMI, they're directly related. Next slide, please. So endometrial cancer, prevention. Again, we can use progestin use, and that could be in the form of oral contraceptive pills. We have oral progestins. We have Depo-Provera, which is given as an IM injection and lasts for a number of months. We now have what's called a Mirena, which is an IUD, which is impregnated with progesterone, which is placed directly into the uterus. It not only prevents conception, but it also, the progesterone is absorbed directly into the lining of the uterus and is very effective at reversing hyperplasia. And the effects of these also persist after we stop treatment. We know that bariatric surgery, weight loss, is consistently demonstrated to decrease the risk of getting endometrial cancer. We now know that there's evidence in rodent studies that the GLP-1 antagonists, the Ozempic, Mounjaro, and so forth, these also actually potentiate in these animal studies the effect of progesterone. So when you're looking in younger women that are obese, that have either early endometrial cancer type 1 or precursors, which is the atypical hyperplasia, that we're treating either with an IUD, progestins, or both, adding one of these GLP-1 antagonists, Ozempic or the like, can also add to the likelihood of reversing their hyperplasia. Next slide, please. Endometrial cancer treatment. Endometrial cancer is a surgically staged disease, much like breast cancer, so we don't assign a stage until after the surgery has been completed. And the surgery is going to consist of removal of the uterus. A simple hysterectomy is all that's required. We remove the fallopian tubes and the ovaries, and we do a lymph node evaluation. And usually that's going to be a bilateral sentinel lymph node biopsies. These are surgeries that the standard of care for is now minimally invasive, and that could be laparoscopic, it could be robotic. These are same-day surgeries with a recovery time of about 7 to 10 days. There is no place in the treatment of endometrial cancer for morcellation, for cutting the uterus up, or what's called a supracervical hysterectomy, where you remove the top of the uterus and leave the cervix in situ, because the lymphatic drainage in endometrial cancer not only goes up through the fundus to the fallopian tubes and the ovaries, but it can go down towards the cervix. So again, it's there are standards of care that are proven to work. And then a low risk disease, when we preoperatively assess these patients, and a pelvic ultrasound is usually sufficient in type 1 disease. Some people prefer to do a baseline CAT scan, which is not wrong. And in type 2 disease, because of the high percentage of metastatic disease, those patients always are referred for CT imaging to rule out distant metastatic disease before we do surgical staging. Next slide, please. We do the sentinel lymph nodes. In the past, going back about 10 years ago, we used to do lymphadenectomies or selective lymph node samplings on both sides, but that was associated with anywhere from a 15 to 25% development of lymphedema. And much like in breast cancer treatment, where they went from removing all the lymph nodes to just a sentinel node, that's what we currently do for endometrial cancer. They receive a dye right before we do surgery. It identifies the sentinel lymph node that allows us to take out usually one or two lymph nodes on each side, and lymphedema is just not heard of since that is done. The test has been proven to be effective, and it does not miss disease. Next slide, please. Okay, so where's this give us here? So in treatment, the majority of patients, because they're going to have low or intermediate risk, surgery alone in most of those patients are going to be curative. In a small percentage of them, adjuvant radiation in the vagina will be all that's required to give them a low risk of recurrent disease. Advanced stage disease systemic therapy is used, including chemotherapy and immunotherapy. And increasing populations of patients now being identified who will benefit enormously from the addition of immunotherapy, specifically Pembro, that is sometimes can even be independent of the biomarkers present. And I think I'm gonna, I think I have 6:28, is that right?
You are correct.
Okay, so I'm gonna hold here.
Okay.
And if there are any quick questions that I can answer, if not, we'll hold it for the end, and I'll introduce the next speaker.
Nothing yet, so
Okay.
you can go ahead and introduce.
Okay, the next colleague that it's my pleasure to introduce is Dr. Katyayani Papatla. She comes to us having finished her fellowship in gynecologic oncology at Mount Sinai, and she's joined me at Greenwich along with Hope, and we're happy to have her, and she's available also 5 days a week. So I'm going to turn it over to her.
Hi, everyone. Thank you, Dr. Dottino, for that introduction. Super happy to be here and to discuss with all of you. Today, I'm going to be talking about management of adnexal masses and kind of what to do, how to triage them. Let me just see if I can. Can you all see that? Okay. So adnexal masses, management of and malignancy risk assessment. I have no disclosures. I just want to say that I'll be using the term female here for the purpose of our discussion, with the acknowledgement that many individuals have ovaries and that gender expression may be different from assigned sex at birth. And EOC will be used to describe cancers of the fallopian tube, ovary, and peritoneum. So some background on adnexal masses approximately 10% of females will undergo surgery for an adnexal mass in their lifetime. So in the US, this number amounts to about 200 to 300,000 females a year. However, less than 20% of these masses will be malignant. So, the large majority of them are benign. The prevalence of epithelial ovarian cancers are approximately 1 case per 2,500 females per year. The cumulative lifetime risk of an average age woman in this country is about 1 in 78, or 1.3%. The median age at onset is 63 years old, and a large majority, 70%, are diagnosed after age 55. As you all know, there are no validated screening methods for epithelial ovarian carcinomas. Oftentimes, these patients present with nonspecific symptoms, and many females will not become symptomatic until late-stage disease. So some of these symptoms are abdominal pain, constitutional symptoms, increasing abdominal size, bloating, urinary urgency. There have been various symptom indices developed in order to sort of standardize how we evaluate these symptoms and what each symptom, what the risk of each symptom being associated with a carcinoma can be. But the outcomes were really varied with these indices, and so it was not recommended to use these.
Dr.
Like
Papatla,
I said,
sorry to interrupt
yeah.
you. Can you just click, somehow your presenter mode went off. Can you click on your screen share again?
Yeah, 1 second.
Bottom, yeah.
Yeah, that's odd. Let me see.
Yeah.
Screen share.
We could see your presentation, but you were still in you weren't in the presenting mode.
Oh.
There you go. Oh.
How's that?
Perfect.
Okay. Yeah, no, thank you for pointing that out. Let's see, where was I? So, so 70 to 80%, because of these non-specific symptoms, 70 to 80% of patients with epithelial ovarian carcinoma are diagnosed late stage. And we know, from years of gathering data and from treating these patients, that the 5-year overall survival in these patients is for about 20 to 30%. In contrast, those that are diagnosed with stage 1 disease have a 90 to 95% probability of cure. So therefore, a thorough preoperative risk assessment is really critical in order to triage those at the highest risk of cancer and refer them to gynecologic oncologists if indicated. So I wanted to, this table is actually taken from one of the American Academy of Family Practitioners resources on management of adnexal masses, because we have many primary care providers, OBGYNs, family medicine doctors, internists that see these patients and are the first line people who are hearing the complaint about pain or an adnexal mass. And so this table just looks at the sensitivity and specificity of the presenting symptoms in order to identify patients with ovarian cancer. And you can see that, sensitivity, which really refers to the test's ability to note somebody who has disease as positive, is quite low for all of these symptoms. It really only becomes high when patients are coming in with 3 or 4 symptoms. And similarly, really the only ones that have the high positive likelihood ratio, so here in that third column, are the 4 or more symptoms or 3 or more symptoms. And this kind of explains why a lot of times these patients do end up kind of not really being diagnosed until later stage. Okay, so how do we assess the pelvic mass? Pelvic ultrasound is typically what I think many of us put in as our first order. The sensitivity and specificity for the pelvic ultrasound in assessing a pelvic mass is pretty good, 86 to 84% sensitive and 94 to 96 specific. However, it does have a relatively low positive predictive value for malignancy, 35 to 40%. And the pelvic ultrasound is also really subject to ultrasonographer subjectivity, skill, as well as inter-observer variability. So one ultrasonographer may not read it the same as another. If the ultrasound is really it's not a good exam, you're not able to characterize it, then the next step would be an MRI pelvis. Characteristics on ultrasound or MRI that are suggestive of a malignancy include cystic solid lesions, lesions that have thick septations, papillary excrescences, mural nodules, increased Doppler flow, especially increased Doppler flow at the area of the septations, and the presence of ascites. So interestingly, even though, we talked about this sort of low positive predictive value for a pelvic ultrasound, as per ACOG, there's, quote, no alternative imaging modality that has demonstrated sufficient superiority to transvaginal ultrasound sonography in order to justify its routine use. So really, it is the best thing we have as the first step for assessing these patients. And I just wanted to show you some examples of ultrasound images in different scenarios, and why this isn't the best, and why it can be confusing. So, on the left side, we have left upper corner, we have a 67-year-old female with a mucinous adenoma on her final pathologic diagnosis. You can see on her imaging that she has a thick septation here with Doppler flow. She has a possible posterior mural nodule. And, ultimately, she's 67, she's postmenopausal. So this, to me, it would be a high-risk ultrasound. She undergoes surgery, and the pathology is benign. On the right-hand side, you have a patient, 25-year-old, presenting with an adnexal cyst. She has really this kind of, fairly large papillary excrescences within a simple cyst. And for her, this is a serous borderline tumor. In the lower left-hand corner, you can see another ultrasound with a mural nodule, a non-vascular septation, some posterior acoustic shadowings, and this patient had a mature cystic teratoma. And then finally, on the bottom right-hand side, there's a 68-year-old with, again, these thin septations. She has some, cystic and solid lesions at the top of her ultrasound here. And this patient did indeed have a high-grade papillary serous carcinoma of the ovary. So, I think my point here is just that ultrasounds are very varied. If you're ever concerned, I think pelvic MRI is a good next step. But there's also other tools that we can use in order to assess somebody's risk for cancer. If you do have a suspicious complex mass, then you can combine the transvaginal ultrasound with the CA-125 in order to help with the risk assessment. So, and we'll talk about this in a little more detail, but just to note that this method is not recommended as screening in average risk populations. There was a large trial called the Prostate, Lung, Colorectal, and Ovarian Cancer Screening Trial. This was a US-based randomized controlled trial that had about 34,000 average risk females enrolled between the ages of 55 and 74. They underwent annual CA-125 and transvaginal ultrasound versus just the usual care with annual pelvic exams. And the positive predictive value for the ultimate diagnosis of an ovarian carcinoma in this population was just about 1%. So this is not something that you would do in the average risk patient who is not presenting with really concerning clinical symptoms. So just to back up for a second, what is CA-125? This is a monoclonal antibody to the ovarian cancer antigen OC-125. It is elevated in 80% of patients with advanced disease, but only 50% of patients with early stage disease. So the way that I tell my patients is that if I'm concerned enough to be ordering a CA-125 for you, even if it's negative, it doesn't necessarily mean that you don't have anything. It is poorly sensitive and specific for early stage detection. Specificity does increase with menopausal status. So postmenopausal women have an increased specificity compared to premenopausal women. However, there are many false positive causes, including fibroids, PID, endometriosis, adenomyosis, pregnancy, menstruation, and even things that are not associated with the gynecologic organ. So kidney disease, CHF, cirrhosis, infections or inflammatory diseases, patients with tuberculosis and other malignancies. So it's always something to keep in mind when ordering this value. And overall, like a one-time measurement is not as helpful as measuring multiple values over time. Before we move on, I just wanted to again include what the AAFP recommends for assessing an adnexal mass. And I think my point of including this here is that the only A-level evidence rating that they really were able to give was that they recommend against the routine screening for ovarian cancer with ultrasound CA-125. We really don't have a good way to screen for it. Moving on, in addition to CA-125, there is a molecule called HE4 that I think we're using more frequently now when assessing an adnexal mass. So this is the human epididymis protein 4. It is primarily released by malignant ovarian cells and thus is less frequently elevated in benign neoplasms. It's also thought to be a marker of metastasis and chemoresistance. And it has good utility in complementing CA-125. So if you think that a patient is at risk for a false positive CA-125, let's say you have someone with an adnexal mass, but she also has chronic kidney disease and she has reason to have a false positive, this adding an HE4 can improve the specificity of the test. It's also useful in those patients who do not express a CA-125. And studies have found that it has greater sensitivity in early stage disease compared with CA-125. Okay, so what are our options for risk assessment? There have been various sort of algorithms or calculators created in order to help us as a field really triage who we need to be worried about, since we can't really screen for them. So one of the first ones is called the Risk of Malignancy Index, or the RMI. This was developed by Dr. Ian Jacobs in 1990 in Australia and had been validated in separate studies in the late 90s and early 2000s. So the RMI uses a formula to assess the risk score of the patient. So the RMI formula is the menopausal status. So you get 3 points if you're postmenopausal, 1 point if you're premenopausal or perimenopausal. So that point number multiplied by the ultrasound score, which is assigned based on a number of features like we discussed, like solid areas, ascites, intra-abdominal mets, multiloculated cysts, and then also multiplied by the CA-125 in units per milliliter. So here, I want to move this over here. I played around with it a little bit, and what I found is that it's very dependent on the CA-125 level and the menopausal status. So in this case, you can see these two patients side by side. I kind of plugged in the same cyst characteristics and the same CA-125. Both of them had a low CA-125 of 12. The only thing that was different is that on the left, this patient has a premenopausal status, and on the right, she's postmenopausal. And so you can see that the patient on the left has a low risk score of 36, so anything under 200 is considered low risk. And the patient on the left has sort of an indeterminate, intermediate, I should say, risk score, not above 200, but I wouldn't say it's, low enough that I would be okay to just watch this person. So that was kind of the number one thing that I noted here. What I also thought was interesting was like, if I changed this patient, so now I kept everything the same, except I included yes to intra-abdominal mets and increased the CA-125 to 45, this patient still had a score of 135, and this is in the presence of intra-abdominal mets. So, I think that this is a study that was probably better used when we had less information, less markers available, for example. Has a large range in terms of suspicious numbers versus non-suspicious values. And, I'm not sure, like I said, that I would ignore a postmenopausal woman with multiloculated cysts and cystic and solid areas with a score of 108, even though it's well under sort of what they call the threshold is concerning of 200. So the RMI in its validation studies, it did relatively well with a sensitivity of 71 to 88%, a specificity of 74 to 97% for identifying cancer. These, again, are the recommendations. So they're saying, above 200, immediately refer to gynonc. Between 25 and 200, the intermediate score, you can obtain an MRI to further characterize, and below 25 is low risk, really just observation, repeat the clinical assessment as imaging. And I think what's also interesting about this, and note about this is that the ultrasound is really key here. So if you don't have an ultrasonographer who is able to, who has high volume, high expertise in commenting on these architectural features, it really makes it that you cannot calculate the score, and it reduces the reproducibility of the score. The next screening method, which I think is much more accepted now today, is called the ROMA, or risk of ovarian malignancy algorithm. So this uses the menopausal status, the CA125, and the HE4 to stratify patients into low risk and high risk groups. The nice thing about this is that it is something that is easily repetitive or easily repeated because it does not incorporate imaging. And it does give you a score ultimately to risk stratify your patients. And there have been multiple prospective and retrospective studies demonstrating the effectiveness of this method. So one validation study in 2011 by Moore et al., they had 472 patients, of which 383 had benign disease and 89 patients had cancer. The patients presented to either their GYN, their family practitioner, or a general surgeon with an adnexal mass. And you can see here that the sensitivity was really excellent in both the postmenopausal and the premenopausal groups. There were actually no epithelial ovarian carcinomas missed in the premenopausal group with a sensitivity of 100%. If you look at every group, all women combined, the sensitivity was 93.8% and specificity about 75%, with a negative predictive value of 99.0, meaning that it's very good at triaging out the patients that you are confident do not have cancer. And it maintained a high negative predictive value of 99%, even in early stage disease. So these were excellent findings. And this study went on to outperform RMI in multiple head-to-head studies. What you can do to improve upon this is combining the ROMA score with your own clinical risk assessment. So really the question here is, how can the initial clinical assessment by a patient's gynecologist or primary provider be optimized using the ROMA? So a 2015 study looked at this combination of the clinical assessment with the ROMA score. This was a retrospective cohort study. Patients who had surgery from 2009 to 2013 for a pelvic mass were retrospectively looked at in this study. So essentially what they did is they had sort of a tumor board process where they prospectively implemented the ROMA score, as well as incorporated a patient's imaging. So that was part of the clinical risk assessment to see how well they did in terms of predicting cancer versus no cancer. So they had about 500 patients, of which 79% had benign neoplasms, 4% had low malignant potential neoplasms, 6% had stage 1 to 2 EOC, and 7% had stage 3 to 4, and 4% had a non-GYN cancer. They recommended, based on their study and using this combination, they recommended observation in 38% of women. All patients with invasive disease had actually been recommended for surgery by using this algorithm. So they were really able to successfully identify which patients needed surgery. Of the 315 patients that had surgery, 212 had benign disease and 84 had cancer. And ultimately, the sensitivity for this method was 100% with a negative predictive value of 100%. And if you look at if you take out sort of the low malignant potentials and other cancers, for stage 1 through 4, so kind of all comers with epithelial ovarian carcinomas, the ROMA alone had a sensitivity of 95.3%. So really the point here is that combining that ROMA score with your clinical risk assessment in the office, so exam, pelvic ultrasound, gives you kind of the best method to triage these patients. So here's kind of the bottom line. ROMA plus clinical risk assessment with an exam and or ultrasound allowed for a highly sensitive triage of patients with epithelial ovarian carcinoma. No invasive epithelial ovarian carcinoma patients were assigned to the low risk group in the study and were therefore missed. So none of these patients were missed. And also 37% of low risk patients were able to avoid unwarranted surgery, which is excellent. I mean, that's our goal, right? Is to reduce unnecessary procedures in patients and to not miss those who really need it. This is the algorithm for this study, so I apologize, it's a little bit small. But on the left side, this is the algorithm of just clinical risk assessment alone. So you can see here that, it doesn't I'll go back to, I'll do more of a comparison. On the right side, you have the clinical risk assessment with the ROMA. And so the point here is that when you get to this place where surgery is indicated, you're then able to use that ROMA and clinical risk assessment to triage into low risk, so those patients that could have surgery done with their gynecologist, versus high risk, who are then referred to a gyn-onc and can have surgery, with or without staging, dependent on the findings. And again, the point here is that, you avoid unnecessary surgeries in the benign patients, and B, you also could avoid patients having to undergo second surgery. So they have their Adnexal taken out with their benign gynecologist, and then you get the surprise path that it's cancer, you send it to the gyn-onc, and then you have a second surgery for a completion staging, which may or may not be more challenging based on, the recent surgery that they just had. There was also a study that did a cost analysis of this combined clinical and ROMA score. So essentially, they basically looked at a clinical assessment alone, ROMA alone versus the combination. And they looked to see if ordering the ROMA test would increase costs. And the bottom line for that is that although the lab costs for ROMA did increase by 55%, this was completely offset by a decrease in OR costs. So there was a decrease in 3% laparotomy costs, 4% laparoscopic costs when you compared the ROMA alone with the ROMA plus the clinical risk assessment. And overall, the total cost decreased by almost 4%. They also had a 63% reduction in repeat surgeries secondary to false negative clinical risk assessments. So ROMA plus clinical assessment is really good to identify those who need surgery, to identify those who don't need surgery, and it is also cost savings in the end. Some of the pitfalls of ROMA, I think really the most important thing, any of us can order it because any of us can order the CA125 and the HE4. So it does not have to just be a gynecologic oncologist. However, the important thing to note is that there are different platforms for these assays, which can lead to different results or cutoff points. So for example, in the pilot trial, they reported these cutoff points in percentages. So a ROMA less than 13.1% was low risk for premenopausal and less than 27.7% was low risk in postmenopausal. But every individual health system or hospital has their own labs that they use that report these values differently. So for example, I put here another platform that I found online for a different individual health system. And here they just kind of reported a number. So for premenopausal, a score less than 1.14 is low risk and less than 2.99 is low risk for postmenopausal. So essentially, if you are ordering this test, if you're in an institution that you can order the ROMA and put that into your EMR and order it, it will show you the result based on your platform's specific biomarker cutoffs. But if you're calculating yourself with CA125 and HE4 values, which we can all do because there are ROMA calculators online, just make sure that you look at the calculator specific to the method that your lab is using. Almost done. I just really wanted to touch quickly on the ROCA, which is the risk of ovarian cancer algorithm for people that are high risk. So these are patients that are age 35 with the BRCA1 and 2 mutation. This is a 2-stage screening strategy using age and change in CA125 over time to assess the risk of epithelial ovarian cancer. And high risk scores are then referred for transvaginal ultrasounds. Really, in the initial pilot study, the patients were triaged based on the CA125 level to whether or not they should just get a repeat CA125 in a year versus in 3 months, or to get a transvaginal ultrasound and be referred to gyn-onc. Overall, they had about 400 patients. The rate of the 3-month follow-up for a CA125 was 5.8%, and the rate of the transvaginal ultrasound and gyn-onc referral was about 1%. Ultimately, they were able to identify 10 patients that had suspicious masses that required surgery. So the ROCA is really not as helpful in the setting of a existing adnexal mass, but where it does come in to be helpful is in patients that you might be following for BRCA mutations. I know a lot of those patients ultimately establish care with gyn-onc and see us regularly, but I have had patients that, see me, and then in 6 months they see their gynecologist, and 6 months after that they see me. So it's kind of an alternating co-management with the gynecologist. And so you may still be somebody who orders this. And really, this is helpful in patients with BRCA mutations who are not ready to have definitive risk-reducing surgery. So for patients that don't want to have their ovaries out yet, it could be useful to do the ROCA risk assessment just to really be able to counsel your patients on when it's time to do this. And lastly, I just wanted to touch on what the joint SGO and ACOG guidelines are for evaluating adnexal masses. So these are direct quotes. Physicians should perform a physical examination, including pelvic exam, a rectovaginal examination may provide additional information, and imaging studies, especially transvaginal ultrasonography, may be helpful. And once the exam and imaging have detected a pelvic mass that is suspicious for a malignant ovarian neoplasm, the presence of at least one of the below warrants referral to gynecologic oncology. Postmenopausal women, so elevated CA-125, ascites, a nodular fixed pelvic mass, or evidence of abdominal or distant mets, and premenopausal women, a very elevated CA-125 level ascites, or evidence of abdominal or distant mets. Patients with suspicious or persistent complex adnexal masses that are requiring surgical evaluation should be referred. Patients with a suspicious mass and strong family history. And then, like we reviewed today, patients who you have done like a ROMA and clinical risk assessment for. So again, that's CA-125, HE4, and menopausal status in combination with your symptoms, exam, and imaging findings. Those are patients that should be sent. And, I want to say that in reality, these exams are often limited and or difficult, and it can be really hard to discern what is a malignancy by office exam or imaging or lab values alone. So the bottom line is that we are happy to see anyone that you're concerned or worried about, regardless of what SGO and ACOG say is the rules for this. So takeaways from my portion, the pelvic exam alone has low sensitivity for diagnosing adnexal mass. A normal exam should not rule out further workup in symptomatic females. Transvaginal ultrasound is the first step as per ACOG, but it isn't perfect, so just remember that. CA-125 and a transvaginal ultrasound has low utility in the average risk women, but it does have good utility, relatively good utility in high risk, like BRCA positive women. The HE4 may help you in certain situations with an indeterminate CA-125. If you suspect a malignancy, consider ordering both the CA-125 and the HE4. The ROMA plus the clinical risk assessment, including imaging, is excellent for triaging females with adnexal masses and helps to expedite referrals to gynonc, to prevent unnecessary surgeries in patients with benign neoplasms, and to avoid second surgeries in those with cancer. If your lab does not offer ROMA, you can calculate it yourself using online ROMA calculators, but just be sure to use those specific to your FDA-approved lab values. I just wanted to give everyone, this is my contact info if you have any questions. This is my cell. This is our office if you want to send patients or have questions about a patient. This is our office number. This is my email. My full name is Katyayani, Katyayani, but I go by Katya. And you can also send me an Epic message. I'm check that kind of like a little bit too much, so I will respond. My references, and I think probably we could save questions until the end unless somebody has something burning right now.
I think we're good. We can go on to
perfect. And then I guess I will do my introduction. Since Dr. Dottino introduced me, I will introduce Hope Walden, who is our lovely nurse practitioner. She has a super cool combination of her NP school and also a surgical fellowship. So we are really lucky to have her because she's able to really be helpful in clinic and also in the operating room. And so she will be talking to you about cervical cancer screening.
Well, that was lovely. Thank you so much. I'm also saying now that the vacuum is going in the office. So if you hear that, I apologize. Hopefully it's pretty good and there won't be an issue. But just before I start, everyone can see my screen. There's no issues with my PowerPoints.
You're good.
Good. Okay, perfect. So, yep, I will be discussing cervical cancer and heavily focused, obviously, on HPV. And before we get into it, I always like to revert back to the basics. So this is a healthy cervix. It's derived from the Mullerian ducts, which fuse to form uterus, cervix, and upper vagina. This explains the way in which cervical cancer spreads, since the upper vagina and cervix share a common embryological origin. The upper vagina is affected before the lower vagina. It connects the vagina to the uterine body, and the cervix helps to prevent infection from ascending into the uterus and fallopian tubes. Here you can see the cervix. It's a tubular structure composed of stromal tissue lined by squamous epithelium. The cervix is approximately 4 centimeters in length and 3 centimeters in diameter. This can vary by age, pregnancy, and menopause. In the picture to the right, you can see, or my screen, I should say the right, but over here, if you can see my arrow, delineated by the blue line is the columnar glandular epithelia, and that lines the endocervical canal. Next, in red, you can see the squamous epithelia, which lines the ectocervix. And then you can see the squamocolumnar junction, also known as the SCJ. And this is the point of which the columnar epithelia and squamous epithelium meet. The SCJ is dynamic and moves during early adolescence and during first pregnancy. The original SCJ originates in the endocervical canal. And as the cervix everts during the times I just mentioned, the SCJ comes to lie on the ectocervix and becomes a new SCJ. And you can see that with the dotted line versus the new. And then next we have the transformation zone. So this is the epithelium between the original and new SCJ. It's the area where nearly all cervical neoplasia occurs. Squamous metaplasia in the cervix refers to the physiological replacement of the everted columnar epithelia on the ectocervix by newly formed squamous epithelia from the subcolumnar reserve cells. And that again occurs within the transformation zone. So a brief history of HPV. In 1949, the first description of HPV was provided by Strauss and al., who used an electron microscope to examine aqueous extracts of wart tissues. In 1963, the physical properties of HPV DNA were described in the study by Crawford and Crawford. And it wasn't until the 1920s that a role of HPV in cervical cancer was postulated for the first time by this gentleman, Professor Harold Zuhausen. He's a German virologist, also known as the father of virology. He subsequently isolated and cloned different strains of HPV. His research concluded that patients infected with HPV 16 and 18 were at an increased risk of developing cancer, and he won a Nobel Prize for Medicine or Physiology in 2008. Sadly, he passed away May 2023. So this, before we can move on, is what is HPV? As most of us know, HPV stands for the human papillomavirus. The picture on the left you can see here is the HPV genome. It's approximately 8,000 base pair circular double-stranded DNA genome encased in a non-enveloped isocohedral capsid. It has 7 to 9 open reading frames divided into 3 regions. So you have your here listed E, or early region. It's in a purple or maroon, not sure how it's coming across. And it contains the E1, 2, 4, 5, 6, and 7 open reading frames. The core proteins E1 and 2 have key roles in viral DNA replication and amplification and regulating viral transcription. The accessory proteins E4, 5, 6, and 7, these proteins facilitate the different stages of the vegetative virus life cycle, primarily by forming virus-host interactions to alter environment of the keratinocyte to support viral replication and enable evasion of host antiviral defenses. And for the high-risk HPVs, which we focus on a lot, the key players of oncogenesis are the oncoproteins E6 and E7. So the L, or late region, delineated in blue, contains the structural proteins L1 and L2 genes. The L1 and L2 proteins form the capsid, as well as L2 having a role in delivery of the viral genome to the nucleus upon infection, and viral genome encapsulation during capsid assembly. And then finally, the non-coding region, which is here in red, and that is your long control region, LCR, and it contains regulatory elements. This region contains binding sites for a plethora of transcription and regulatory factors that either activate or repress the early or late and late promoters, the origin of replication to which E1 protein binds, as well as multiple binding sites for viral E2 proteins. And the right-hand picture, this is for, again, our high-risk HPV proteins, oncoproteins E6 and E7. So HPV increases basal cell proliferation and forces basal cell to tolerate mutations through these two proteins. And E6 inhibits P53, and E7 retinoblastoma, also known as RB, which you'll see here. You can see my cursor. The E6 protein blocks the binding of transcription factor P53 to the promoter of pro-apoptotic genes through its binding with ubiquitin ligase E6AP, thus inducing its proteasomal degradation. Again, E7 oncoprotein induces the RB degradation for promoting S phase entry. The E7 because of this protein, the P53 and your RB proteins, they're critical in the cell cycle checkpoint proteins. So with these not being around, it really prevents the protection that it's needed. Again, the way it looks as proliferation begets mutation, and mutation begets proliferation immune system escape. So over time, with repeated and chronic infections, the basal cell develops sufficient mutations that become malignant. So HPV types and its spreads. There are hundreds of HPV genotypes, and there are about 12 to 15 high-risk HPV serotypes that cause several types of cancers. The two, again, we focus on heavily are HPV 16 and 18, as they are the two cervical cancer-inducing HPV serotypes responsible for 70% of cervical cancer. It typically, HPV resolves within 9 to 12 months and can almost clear within 2 years. But during productive cervical HPV infection, low-grade cytological abnormalities may clinically be detectable in screening, usually transient. However, the carcinogenic HPV 16 and 18 infections that persist beyond 12 months increase the likelihood of precancerous or cancerous lesions, although not all persistent infections progress. In the United States, the median age of cytologically detected precancerous cervical lesions occurs approximately 10 years after the median age of sexual debut. HPV can enter a latent state. Additionally, there's evidence for cervical viral reactivation in some populations, including females with HIV and older females. However, it's unknown whether all or any subset of HPV infections become latent and whether reemergent HPV infections carry significant cancer risk. So here I have a couple listed of the genotypes. You have your, cutaneous, which is your non-genital warts. These types have a predilection for cutaneous epithelium and are found in plantar warts, common warts, flat warts, butcher warts. These are types, HPV types 1, 2, and 4. For your plantar flat warts is types 3 and 10, and the butcher warts is 7 and 2. The anogenital epithelium, these HPV types have a predilection for the anogenital keratinized skin and mucous membranes infection. So these common sites are your penis, scrotum, perineum, anal canal, perianal region, vaginal introitus, vulva, and cervix. For your genital warts, HPV 6 and 11, and these are benign anogenital warts. And then the squamous intraepithelial lesions and or carcinoma of the vagina, vulva, cervix, anus, or penis, and that's your high-risk HPV types, 16 being the most common and having the highest risk of progression of cervical cancer. Other mucosal services, HPV 16 can infect the oral mucosa and has been associated with squamous cell carcinoma of the oral cavity. Again, related disease in females, your cervical cancer. It's the fourth most common cancer among females, with approximately 570,000 cases of invasive cervical carcinoma diagnosed and 311,000 cervical cancer deaths annually. What are the risk factors and how can we prevent it? So risk factors for HPV, multiple sex partners, not using a form of sexual barrier method, so male or female condoms, age, young age at start of sex, particularly under the age of 18, excuse me, and then cigarette smoking alters cervical secretions, which increases the chance that an HPV infection will be established and worsen the chance that it will be cleared. And then lastly, but not least, your STIs. A study performed by Abreu and al. In 2016 took 838 women aged 18 to 68, screened using pap smears for cervical abnormalities such as HPV, non-HPV STDs, and they used PCR and MPCR methods. They were looking for chlamydia, gonorrhea, mycoplasma genitalium, trichomonas vaginalis, HSV 1 and 2, and then trichinoma pallidum. What they found was that the primary pathogens associated with high-risk HPV were the chlamydia and gonorrhea, increased risk for all grade of cervical abnormalities, mainly for high-grade serous squamous intraepithelial lesions, suggesting a possible synergistic action in cervical lesions progression. And how can we prevent this? So safe sex practice, that's condoms, monogamy, waiting until you're older, and then, of course, vaccination. I'm not going to spend too much time on this slide just because for the sake of time, but this just gives us a brief overview, starting from 1951 with Henrietta Lacks. For those of you, that's the one thing I will bring up is Henrietta Lacks. She was a woman who developed cancer in cervical cancer at the age of 30. She had sought treatment at Johns Hopkins University with Dr. George Gay, and he took a sample of what later became known as the HeLa cells, named after Henrietta Lacks. And this is really what sparked the profound impact that she had on major scientific discoveries, not only just with the link between HPV and cervical cancer, but the polio vaccine. So here we're going to discuss the vaccination guidelines. So the CDC, you can see here, Advisory Committee on Immunization Practice, so the ACIP, what they list here on the right-hand side. Routine vaccination at age 11 or 12 can be started at age 9. Vaccination for everyone through age 26 is not adequately vaccinated when younger. And then vaccination is not recommended for everyone older the age of 26. Some adults 27 to 45 might decide to get the HPV vaccine if they did not get it adequately when they were younger. And then vaccination in this age range provides less benefit for several reasons, including that most people at this age point have already been exposed to HPV, and the vaccine prevents new HPV and obviously does not treat existing HPV infections or disease. Your dosing schedule is a 2-dose schedule, and it's recommended for most persons starting in the series before their 15th birthday. The second dose of HPV vaccine should be given 6 to 12 months after the first dose, and adolescents who receive 2 doses less than 5 months apart will require a third dose of HPV vaccine. 3 doses of HPV vaccine are recommended for teens and young adults who started the series at age 15 through 26, and for immunocompromised persons. The schedule is 0, 1 to 2, and 6 months. 3 doses, like I mentioned, immunocompromised persons between ages 9 through 26. And then this chart here to the left are the 3 HPV vaccines licensed in the United States. The one exclusively being used and moved to is the 9-valent HPV, as it's covering the most HPV infections. Contraindicated contraindications and precautions, if you have a severe allergic reaction, such as anaphylaxis to Saccharomyces cerevisiae, I'm probably butchering that, but that's essentially baker's yeast. That is an absolute contraindication if you have a hypersensitivity to that. Moderate or severe acute illness, you would just hold off until it has run its course, and you can give the vaccine. And then minor acute illness such as diarrhea or upper respiratory infection, you can give it without any concern. HPV vaccine is not recommended for use during pregnancy and should be delayed until after pregnancy. There's no study proving that it's harmful. However, it is recommended to wait until after the pregnancy. So screening for cervical cancer in the United States. As I mentioned before, HPV 16 and 18 are responsible for 70% of cervical cancers, and this can be prevented by regular screening of women and the vaccination of children. Your Pap test begins at age 21, regardless of your onset of sexual activity, and it recurs every 3 years. Co-testing starts at age 30, and screening shifts to the co-testing, which is the Pap test with HPV testing every 5 years until age 65, if they have been negative. Pap testing before 21 or starting HPV before 30 increases unnecessary procedures that are both painful and can compromise future fertility. You can see here, this is the USPSTF versus the ACS guidelines for cervical cancer screening. So the American College of Obstetrics and Gynecologists, ACOG, joined the American Society of Colposcopy and Cervical Pathology, so the ASCCP, and the Society of Gynecological Oncology, SGO, in endorsing the USPSTF, which is the U.S. Preventative Service Task Force, cervical cancer screening recommendation. So what would be followed was this, and then this is the American Cancer Society. Moving on, cytology outcomes. So now you've done your Pap test, you've done your HPV co-testing. What do the results mean? So some cytology outcomes you have are negative for intraepithelial malignancy. This means the specimen was adequate for evaluation and there's no epithelial abnormalities identified. Next, you have what's referred to as ascus, cells that display abnormalities more marked than simple reactive changes, but do not display a squamous intraepithelial lesion. In some cases, these lesions are associated with cervical intraepithelial neoplasia, also known as SIN, and we'll get into that later. You have your low-grade squamous intraepithelial lesions. These lesions are associated with HPV and tend to be associated with transient changes that regress over time. Atypical squamous cells cannot exclude high-grade squamous intraepithelial lesions. These cells likely consist of a mixture of true high-grade squamous intraepithelial lesions and other findings that mimic such lesions. You have atypical glandular cells not otherwise specified. This was formerly known as AGUS and has recently changed to either endocervical, AEC, endometrial, or not otherwise specified. And then your high-grade squamous intraepithelial lesions associated with high-risk types of HPV and that have high risk of progression to CIN or cancer. And last but not least, carcinoma, squamous cell cancer, adenocarcinoma. So squamous cell carcinoma of the ectocervix caused by HPV, and then adenocarcinoma of the cervix. The adenocarcinoma of the cervix, the endocervix, is a Mullerian malignancy. It's a cancer derived from the descendants of the Mullerian ducts, as we talked at the very, very beginning, why it was important to make that note of this Mullerian malignancy. The simple columnar epithelium that invaginates upon itself to form these glands. It is a mucinous phenotype for Mullerian malignancies, commonly encountered as a mucinous variant of ovarian epithelial tumors. And it's rare, but obviously dangerous. So here we are, cervical intraepithelial neoplasm, CIN. There are 3 different grades, 1, 2, and 3, and they go from low grade with mild atypical cellular changes of the lower third, CIN2, which is your high-grade, moderately atypical, change confined to the basal 2 cells, 2/3 of the epithelium, and then 3, which is your high-grade lesion with severely atypical cell changes, and that it's encompassing more than 2/3 of the epithelial thickness and includes full thickness lesions. For CIN1, yes, so a patient's risk for progression to cancer is related to in large part by age and your CIN grade. So ages greater, younger than 25 years have a low risk of developing cervical cancer than patients 25 and older. And again, the CIN grade has a low potential, CIN1 has a low potential versus a CIN3 and CIN2, which have higher potential for progression and a lower potential for regression. So what do we do? So the 2019 American Society of Colposcopy and Cervical Pathology, ASCCP, put out this really, really great app, which I'll get into, and I'm going to hope I can show you. But essentially, in collaboration with multiple professional societies and government organizations, the United States and Canada published practice-changing consensus guidelines regarding the evaluation and management of cervical dysplasia. The consensus recommendations are based on the principle of equal management for equal risk. So earlier today, I think Jenny might be on the call, she's like, well, this is what we got for our pap smear HPV co-testing test. What does this mean? And it takes in a lot of things as far as, well, have they been HPV positive in the past? What are their histories? It's more than just what it is today. It takes into the whole account of the person. So again, this means the same current screening results may lead to a different management recommendation for one patient versus another patient, depending on the past testing results. So I'm going to see if I can bring over this screen so you can see. Can everyone see this now? I don't know if anyone can see it. Yeah, so this you can actually download as an app for providers, nurses, whomever, or if you just want to play around with it. And you literally just plug in exactly what it is that is popping up. So, age 30 to 65, they came in for routine screening. And this is a pick your own. So if you pick one, the other one clicks off. So let's say a routine screening. Next, what it came back. Their HPV was positive. Ours are usually always genotyped. And we'll say that these were present. And then cytology, what did it come back as? So we'll just say ask us. Does the patient have previous set? We'll say no. And then it will map out exactly what it is, confirming these are exactly what you put in. And then it tells you recommendation, colposcopy, risk, intermediate risk of CIN3 plus is 9%. So it's a really great tool. Again, you can put it on your phone. For me, who's new to gynecology, oncology, it's a great resource and I love it. So I highly encourage. But like it recommended, so colposcopy, it can be diagnostic and therapeutic colposcopy with excisional biopsy, which we've done here in the office. So you have your ectocervical and endocervical curettage. Excision, your loop electrical excisional procedure known as the LEAP. And then your ablation, so your cryotherapy, cold knife, and CO2 laser. How am I on time? Okay. So finally, what is the future of cervical cancer? So in 2030, the WHO hopes to meet milestones on path to eliminating cervical cancer. After meeting the 90-70-90 targets through a global focus on vaccination, screening, and treatment, the WHO hopes to eradicate vaccine-preventable cervical cancer within the next century. 90% of girls fully vaccinated with HPV vaccine by age 15, 70% of women initially screened with high-performance testing by age 35 and a secondary test at age 45, and 90% of precancers treated and 90% of invasive cancers managed. Strategies towards the elimination of cervical cancer as a global public health problem. The guiding principles, life course and public health approach, social justice and equality, integrated people-centered health services, and then the challenges that we face limited supply of the vaccine, cost and affordability of the vaccine and delivering treatment, the methods of which we deliver it, and then quality pathology. And last but certainly not least, therapeutic vaccines. So therapeutic HPV vaccines deliver tumor antigen to stimulate an immune response to eliminate tumor cells. Vaccine antigens delivery platforms are diverse and include DNA, RNA, peptide proteins, viral vectors, microbial vectors, and antigen-presenting cells. Randomized control trials have demonstrated that therapeutic HPV vaccines are efficacious in patients with cervical with CIN. In patients with HPV-mediated malignancies, evidence of efficacy is limited. However, numerous ongoing studies evaluating updated therapeutic HPV vaccines in combination with immune checkpoint inhibition and other therapies exhibit significant promise. So here are my references, and I will stop sharing, and hopefully that gives us 5 minutes for questions. I'm sorry.
No, it's great. Thank you. The information is amazing and very well appreciated. We have 2 questions in the Q&A. I will just shout them out there. I think the first one came in while Dr. Dottino was talking. How do you feel about ultrasound screenings annually? And don't forget that you're on. Yeah, there you go.
I think that there's really no proven role for it. For annual screening, I think it will end up with, as Dr. Papatla already said, it end up to far more unnecessary surgery being performed. I think when you couple it with the symptoms the patient has or your index of suspicion based on your physical exam, the patient's personal history, then the use of a sonogram, I think, has got value. But just to say, I'm going to send somebody for one every year, it's just a waste of healthcare resources.
Okay. And our other question is, do you see artificial intelligence leading us to an earlier diagnosis of ovarian cancer?
There actually, interestingly, there's a new study that's going to be published in the Gynonc March 2024 edition, the Gynonc Journal, looking at like a very preliminary study. It's out of Georgia Tech, I believe, and they are looking at using AI plus like a combination of a number of metabolic, I guess, indices that can be tested in the blood to see if they can come up with a profile. So what they're doing, my understanding of what they're doing is that they're taking patients that they have that have known ovarian cancer versus nothing, and they're trying to establish some kind of score based off of this metabolic profile that they're building. So I think that there is going to be a role for it, but there are also a lot of, I think, downsides of AI that we have to remember in the future as we apply them to our patients. So look out for that article.
I would add to that and just say that one of the programs that I brought with me to Yale is early screening for ovarian and endometrial cancer, and there we use a form of what's called machine learning, which is a type of AI, and we had done all of these studies and collected all this data and didn't think we had anything worthwhile until we met with the bioinformatics specialist, and they began to train our systems using machine learning. And then we discovered things that we never thought was visible in this data, and it wasn't visible until we used these systems. So I think they can just add an enormous amount for analyzing large sums of data. But as Dr. Papatla just alluded to, you have to train these systems, and that means they've got to see huge amounts of data, and you also have to be very careful about overfitting your data for what you're really looking for. But I don't think there's any question as these systems undergo refinement that these are going to become part of pretty much everything we do in medicine. They read mammograms better than most radiologists today, there's a lot of places where they're already doing that. They're going to be reading our CAT scans, or your radiology is going to be looked at with AI, because again, it has the capacity to process through data and refine it into very interesting ways for patients. So yeah, I think it's a great question.
And we have one last one. What is the role of uterine transplant in young patients with endometrial cancer?
It's
My
been
Yeah, go.
used. It's highly experimental. I don't remember where exactly it was done, but I just don't believe it's anything that's really taken off to my knowledge. And that's what I'd have to say about that.
I think it was somewhere in the UK, but I agree. I've seen animal studies, but I don't know how well they translate into human at this point.
Okay, so thank you everybody so much. I'm going to end with one more comment that we had in the Q&A that said, thanks so very much. We have a lot of worried women and we appreciate this talk and you being here. So I will second that and thank you so much for your time. Thanks everybody for hanging in with us and spending your evening with us.
Thank you.
Have a great night.
Thank you. Have a good night.
Thank you.
Bye-bye.